You.
Very good morning.
Can you hear me?
Yeah, I can. Hi, Deepthi.
Hi, can you hear me?
Yeah. Uh, oh,
Hi, Victor. Good to see you again.
Very good to see you. Thank you for having me.
Of course.
and just before that, Victor, you see here the stop sign share
Say that again. Yeah, yeah, yeah.
next.
Yeah, yeah.
So that's the button which you
Can
will
you,
be
it,
sharing.
it,
Yeah.
can you see my presentation?
Yeah, I can see, but it's on only one corner. It might not be in the presentation mode.
So it is, you're seeing the presenter's view.
Not
Okay,
not in that way.
okay, that's fine. Put this way. Boom, boom, boom. And now it's correct. Yes?
Yeah, now it's correct.
Okay. All right.
Great. I was waiting and helping Gopal to join it. He's traveling, but seems that he's facing technical issue. So we are good to start. And I think there is some changes happened somehow, but generally it's the start of the meeting, which is not showing us someone have activated that. So no issue. So very good morning, everyone, including Victor and Deepthi and all others those who have joined this call. And it's a very pleasure to look forward to hearing Victor's and Deepthi is the one who's very keen and very passionate about the patient and how that's going to be revolutionized in the way the technology is coming up. So hand over to Deepthi, and I will be here helping um, and looking forward to.
Thank you. Thank you, Akram. And a very warm welcome, Dr. Montori, Victor. Um, I have been a fan of your work from, I think, when I was back a resident and have been following it very keenly, even when I was in Minnesota. And I think we crossed paths a few times. But to me, everything about care needs to be patient centered. And I come from a design background about user centered design in digital care. So this topic is very near and dear to my heart. By way of introduction for the audience, Dr. Montori is a physician, an endocrinologist, a health service researcher, and a care activist. He has innumerable publications, and currently he's also the Human Rights and Technology Fellow at Harvard Kennedy Institute. He's a recognized expert in evidence-based medicine, shared decision making, minimally disruptive medicine, and he works at the Mayo Clinic in Rochester and has started this huge concept of the patient revolution, which has now morphed into care. And we are delighted to hear a little bit about his journey and what care stands for. And with that, I'll hand it over to you, Victor, and then we might have some follow-up questions after your presentation.
For sure. Thank you very much, Dipti and Ikram, for inviting me. And just double checking that you can hear me okay and you can see the slides in presentation. Very good. Thank you. This first slide has my email address, and I welcome anybody to follow up with me. If at any point your question doesn't get addressed today, I'll be happy to get email from you. This is a depiction that I think is going to be fundamental for our discussion. Healthcare has at least these two functions when it comes to patient care. It can cure or it can care. It is in the space of cure, which is where most of medical education and tradition comes from. How do we fix this person? Usually after that person has experienced trauma, or maybe there's an infection. How might we fix this person, return this person to full health? It's in this context that there is the notion of right patient, the right diagnosis, the right cure, correctly deployed at the right time, the first time, with the right expertise and equipment. And a lot of the quality improvement methods, I think, are perfectly designed for this situation. Also, some of the guideline work, particularly when guidelines turn into must-dos, strong recommendations fall in this area. I recently had cataract surgery because of trauma on my left eye, and I experienced this form of right care where I was just put in a chair and I was moved through what felt to my body, at least, as a conveyor belt, and where the operator on my eye did not have to have a relationship with me or with or even with my eyeball, but had to really basically correct the problem of my cataract and do it properly the first time. This is a patient that was seen at the Mayo Clinic a few years ago. A decade before, he had attempted suicide with with a gun aimed at his face, and managed to destroy his face, and went through multiple operations in order to save his life and then to give him some function, but that was not totally successful. The work that followed required more than 80 people, 9 months of preparation, and 2.5 days of surgery with 6 surgeons and a very large staff to be able to do a face transplant, which was touted and highlighted by the organization in all the news. And when he was asked what he was going to do with this now that he was fixed, was that he was going to become or continue to his work. He was going to rebuild his life. He was going to find a partner, maybe have a family, and he was now going to focus on work on helping people with mental health issues. He was going to work on care. And so he himself had what appeared to be episodes where people have tried to fix the problem, interspersed with what is at least a decade and will continue to be the work of care. And that work, the work of mental health issues and the work of rehabilitation and the work of chronic conditions work is, I think, the most important work we do in healthcare today because it's your numbers. This is the one of the multiple epidemiologic graphs that are available that show the tendency across the world of people accumulating chronic conditions as they age. And most people focus on, oh, yeah, look, over the age of 65, almost everybody lives with 2 or more chronic conditions. But I also draw attention to the middle of the graph, the middle age group, which the average person no longer is a healthy person, but is a person who lives with at least one chronic condition. So the core competency of any healthcare organization that is caring for a population, particularly for adult population, is going to be the ability to actually care for people that we cannot fix, care for people with chronic condition. And this is really what I do for a living as a diabetes clinician. I help patients manage symptoms, mitigate adverse effects, cope with disappointing results, prevent complications, rehabilitate sequela, self-management support, problem solving, making care fit the lives of people. And this, of course, is also the core work of my colleagues in primary care. So when we think about caring for people with multimorbidity, we're not in the cure space for the most part. We're in the care space. Now, notice that in this graph that I made, the line doesn't go from corner to corner. And that is because even as in the case of the gentleman with the face transplant or the patients that I see in diabetes, there's always, even when we're intent on curing, there's always a space for care. And when we're focused on care, there's always the opportunity, sometimes in the case of diabetes, say type 1 diabetes, the possibility of a pancreatic transplant is there. So there's always going to be the need for both competencies, but we need to make sure that we don't confuse them as we go forward in improving care, to think that we are perhaps in a place of identifying the right answer, when in reality we're dealing with with significant wicked complexity in the care of patients with chronic conditions. Here's one such patient, is Maria Luisa. She's from Peru, like I am, and she's been on my presentations for over a decade. And this is a picture that her granddaughter took of her in her home, where Maria Luisa is looking at her medication program right in front of her as she's having her breakfast. And despite all those medications, Maria Luisa doesn't appear to be particularly healthy. She seems tired, frustrated, perhaps overwhelmed. Um, in healthcare today, we have a problem of seeing patients well. We basically focus on their diagnostic labels. And in fact, some technologies are now very focused on making sure people would get the right diagnostic labels. Diagnostic labels that, in the case of Maria Luisa, perhaps describe each of the biological systems or problems or diagnoses that she has that describe this physiologic disturbance. And as a result, we look at those diagnoses and we have guidelines and we identify the treatments for those diagnoses. And she ends up with those pills in front of her, which are, reflecting of care for people like Maria Luisa. But that is not the job. The job is to care for Maria Luisa. And to do that is not enough to respond to her biology, but we must also respond to her biography, not just to what makes her subject to the treatments that we offer, but what makes her particular among folks with the same diagnostic labels. Biography is important because it reflects the notion of understanding where she's coming from, both in terms historically, in terms of adverse childhood experiences that we know are determinants of chronic conditions, the socioeconomic and political circumstances of her upbringing and of her life to date are all contributing not only to the development of those conditions that she has, but also to the expression of those conditions in the form of illness and symptoms, and how the disability that results from those symptoms and syndromes affects her ability to live her life. But biography also speaks about the future. How are we going to, what are her goals and priorities going forward, and also speaks of her present. How is the conditions and the treatments affecting her ability to live her life, and how is her commitment to live her life affecting the efficacy and safety of the treatments that we're offering her? Without recognizing biology and biography, without seeing Maria Luisa in high definition, we see her only as a blur, and we will respond to her only with this generic care for people like her, which again is not the job. Furthermore, when Maria Luisa comes to healthcare, she is seen not just as the reason for the existence of healthcare organizations, the reason for coming to work for clinicians, administrators, technologists, and other folks that have made a commitment to work in healthcare, but she's also seen as a resource, as a source of work that the organization can leverage to deliver its services. And Maria Luisa and her family are increasingly being asked to do more as patients. In the case of Maria Luisa, she could easily be expected to come with organized information, ask prioritized questions during the visit, record the visit for further review at home, to review the medical record for typos, to use the portal, transmit data from self-management system, to self-monitor, to educate herself, to manage appointments, denials, bills, to overcome identity troubles, to keep herself informed and others, and advocate for herself, advocate for others, and also to wait. Maria Luisa and her family will be asked to wait for appointments, to wait for test results, to wait in the waiting room, to wait in the doctor's office, to wait for pre-authorizations, to wait for the prescriptions to be renewed, to wait for the fax. There's always going to be faxes to wait for, and you have to wait. And all of this is going to overwhelm Maria Luisa and her family's capacity to do the work. And when she doesn't do the work, when she doesn't show up for the appointments, the way we're going to respond to her will be not with understanding of the difficult situation in which she is, in which the workload that has been transferred to her has overwhelmed her capacity and her capacity for family and caregivers to the work, but we're actually going to see her as a fault in her character. And we're going to describe Maria Luisa, not her situation, Maria Luisa herself, as non-compliant or non-adherent or whatever the euphemism will be. We're basically going to mark her with a signal that she is a bad patient and one that will not be a good partner with us in helping us achieve the metrics that we are being held accountable, indicated by the guidelines and signaled by the quality performance metrics and by the contracts, the pay for value contracts that our organizations often sign. And so she become the enemy. This is what I just described is industrialized healthcare. The sense that you're on a conveyor belt in a system that's trying to fix what can be fixed instead of caring, where you're seen as a blur, right? And in high definition, receiving treatments that are generic and burdensome and sometimes cruel. Um, this is not just cruel to the patients that are seeking care, but it's cruel to the caregivers. This industrialized system creates conditions that actually induce in professionals a sense of moral injury that upsets us until we run out of energy and become cynical and burned out. This is work by Mark Linzer that happened to overlap with the bit of the pandemic, which in the middle shows the rate of burnout over years between 2019 and 2021, around 40-45% on average. But that average hides two groups, a group that is actually not as bad and a group that is much worse off. And the group that is much worse off is a group of clinicians who does not feel, works in environments that do not where they do not feel valued, where they have limited control of their work conditions. They cannot work in teams, and they are forced to work in hurried and chaotic environments. So these are the environments of industrial healthcare that actually are burning clinicians up. And these are environments in which care itself is not possible. And when it's possible because of the heroics of patients and clinicians, it's rendered unsustainable, not just financially and environmentally unsustainable, but humanly unsustainable. It is in this environment where, 40%, so 70%, I saw a recent statistic, 70% of clinicians experience moral injury, 40% have left or intend to leave the practice. 40% of the agenda of the visit is about the patient's agenda, but most of the agenda is actually focused on disease management, the processing of the patient, of delivering the care for people like this, rather than caring for this person. That agenda comes into focus when it's patient-centered because patients get to tell us why they're there, but we interrupt them within 11 seconds of their statement of that agenda. And then when we're together, we're spending half of the time looking at the computer screen. The result for patients with multiple chronic conditions is that for 40% of them, they report unsustainable levels of burden of treatment. That means that they're about to discontinue some aspects of their care. This is not the performance of the best healthcare system in the world. In that way, patients with chronic conditions and the clinicians that care for them act as the canary in the coal mine. Canaries were used in coal mines until surprisingly recently. This picture was apparently of the last canary in a coal mine in the UK. It was taken in 1986. And the way this sensor worked is they will bring the bird into the coal mine, and if the environment was toxic, the bird, because of smaller lungs, breathes quickly, will be the first one to show the signs of that toxicity, alerting the miners that it's time to leave the mine because it become toxic. The way the birds will react to the toxicity was not, as many people think, that it would just drop dead. That will be a lagging indicator. The way this will work is that the bird will become restless. And after being restless, if the exposure continued, the bird would stop singing. The bird stopping singing feels a lot like clinicians becoming despondent and leaving the practice. Sounds a lot like patients not showing up for care. Sounds a lot like younger patients preferring to be texted about their healthcare than showing up for appointments that are not about themselves and their system. So if we think about healthcare systems and their improvement tasks. Focusing on patients with chronic conditions and the clinicians that care for them allows for healthcare systems to develop a level of patient-centeredness and a level of responsiveness to care that would be excellent, which is not where the attention has been. The attention has been on getting the right answer at the right time to the right people, has been focused on cures. So how might we respond to this crisis of care? With Iona Heath, a brilliant GP from the UK, we wrote this paper a few years ago where we asked this question, and I'll just read it verbatim. You know, our one response to the crisis of care is to assume that it's a crisis of organization, of efficiency, of information technology, of scale. And that means that in order to solve it, we need to force ourselves to operate at scales of speed and reach that are only possible when we abandon the idea that care is only possible between people. Things like artificial intelligence become really attractive under this set of assumptions. But responding in this way requires more consumption of data, of medications, of technologies that ignore the consequences for other economic priorities or for the planet. So we put forward that another way of responding to this crisis of care was to focus on care itself. So what is care? It's surprisingly hard to define what our core mission is. One way of thinking about it is that care is a practice, a series of rituals and things that we do. And it's also a disposition to respond to the needs of others with effective care. The ethics of care from John Tronto suggests that care is also noticing and responding. So noticing is the idea of being present, of realizing that this person in front of us is in trouble, is in a troubling, problematic human situation, and that requires action. That noticing, sometimes when it focuses on the emotional aspects, is called empathy. But noticing that somebody's in trouble is the first step, but it's insufficient. Just like empathy, feeling like that person is in trouble is also insufficient for care. We must also choose to respond. It's in choosing to respond. It's in the idea that we don't turn away from the one that is who is suffering, but we turn toward them and then think about creatively about how we're going to respond to the situation. That is what gives people hope, that perhaps if we do something now, their immediate future will be different, will be better. So care is noticing and responding. It's also caregiving and care receiving. And caregiving is where we mobilize in having taken responsibility, having decided to respond. This is where we mobilize our competence so that we don't do more harm than good, and our compassion so that we attend to the emotional aspects of things. This is when we mobilize competence and compassion to actually improve the person's situation. But the assessment of care is not complete until we also have care receiving. And care receiving is what patients and their caregivers assess, and to what extent the care that has arrived, that they have received, is pertinent, is adequate, and is desirable. So it's not sufficient to say, well, we cared, but we need to make sure that that care that was given was actually good, and good care for this patient. What I've described initially in industrial healthcare is a series of pathologies of care, things that get in the way of care, as I just described. And I think we need to move away from that industrialized form of healthcare. I think it's an undesirable development of in healthcare. We need to turn away from it. It's not good for us as humans. And we need to move towards a different model, a model of careful and kind care. Careful and kind care starts by cultivating care. It starts from the leadership of organizations and from the commitment of professionals with moral leadership. It starts by pointing out that care is healthcare's core purpose. We are not, healthcare is not another industry to generate income for investors. Healthcare is an investment in people's flourishing. And we need to, when we talk about healthcare, we need to make sure that we tell stories about care and use those stories to drive care. Too often we focus on access to it and how to pay for it. And we seldom talk about it being care. And the result of that is our language becomes filled with the language of business and devoid from the language with the language of care. And we need to move from fixing problems only, or at least in our language, to start, creating the resources and supporting the people that help others cope, adapt, and thrive. The definition of health in people with chronic conditions. We need to stop thinking about variance as defect, which is the appropriate mindset when it comes to fixing, to start thinking about variance as virtue, which is the right mindset when we're constantly trying to adapt to the needs of each individual person with chronic conditions that we see. And we need to think about this line as actually a porous line where everybody that comes in for cure absolutely needs care, and everybody that comes in for care sometimes can benefit from cures. to to do this at the micro level, we need to think about the relationships. And this is the cathedral from Rodin. It's my favorite sculpture, two hands from different people coming together, almost touching at the fingertips. The sides, the palms of the hands forming the walls of the cathedral. The space between the hands is what makes the cathedral a place where it serves its function. And similarly, in the clinical encounter, patient and clinician are coming together, and it's the space between them where the encounter does its magic. That's where care takes place. Just like Rodin here had to chip away at the rock to create that space between the hands. In healthcare, we need to chip away at anything that gets in the way of clinicians and patients coming together for care. So we also need to focus on radically changing the conditions for care. And that includes the well-being of people. We need to make sure that the clinicians, those who come, have the privilege of being at the bedside of patients that are coming in for care, patients are well, and their competence is actually cultivated. We need to make sure that they can work in teams, so they not only are better together, but also they can care for each other and be well when they're interacting with patients. And when we bring technologies and innovations into this space, we need to make sure that we don't only do a financial impact analysis, but we also do an impact on care analysis to make sure that there are no unintended consequences that get in the way of care, or that the supposedly positive impacts on care are truly realized. And then we need to bring forward the signs of care. These are the opposite of the pathologies of care. So instead of blur, seeing people in high definition in terms of burdens, providing minimally disruptive care. Instead of hurry, seek unhurried conversations. And instead of cruelty that comes in healthcare most often from indifference, bring forward responsiveness. So what are examples of things we could do for seeing people in high definition? There's a movement globally about asking people what matters to you, and make that the answers available to all the healthcare team. Be curious about patients' lives, something that requires one to have mental and emotional availability to actually be interested in the other. Many healthcare experts talk about the lack of patient engagement, but the main problem we see after analyzing thousands of videos of patient-clinician encounters is a lack of clinician engagement in the lives of their patients. And we need to make sure that we understand the patient's biographical data and find out ways of actually bringing them to the fore. Maybe it is through the electronic health record. We need to make sure that as we improve our systems, we don't see the patients and their families as an untapped resource, but where it's subject to delegation of medical chores and errands. We need to understand when people don't show to appointments or exhibit low fidelity to our treatment programs, and think about as problematic circumstances, not as character flaws of our patients. And it would help if we don't have quality metrics that then render that patient and their family as the enemies of our performance or our reputation. We need to make sure that we simplify care focusing not just on the lean production side of that work, but also on the lean consumption. So how do we reduce waste in the use of the services by patients and their families? And we need to promote patient capacity so that, through emotional and practical means, the work of healthcare doesn't have to compete in disadvantage with the work of living. We need to make sure that we limit interruptions and distractions during the clinical encounter. And of course, a core distractor right now is the demands from the electronic health record. And we need to redesign those systems to make sure that they support the central role that those encounters have in caring for people. We need to enact responsive scheduling. Right now, all these talk about incredible technology, and we have many places in which the way the calendar is set up is how many patients do we need to see to make our targets, okay, how much time do we have, and that's the schedule. And we should be much more responsive to the individual needs of patients and the individual characteristics of our clinicians so that they are optimized to those and not optimized to the system. And we need to implement and defend the continuity of care. Continuity of care saves resources, is better for relationships, is superior in terms of outcomes, including mortality. It reduces the consumption of diagnostic tests, but it is actually really hard to enact in an efficient way. And we favor efficiency and access over relationships and continuity. And I think that might be good for cure, really not good for care. And we need to eliminate wrong doors, the people that have to go from one place to the other because we didn't clarify where they need to go to get the care that they need. We need to make navigation easy. We need to make care easy for people, not only for those receiving it, but also for those giving it. We need to eliminate cruelty. This is a picture that I took from the interwebs. I do not know where it was taken, but of people waiting in line and eventually got tired and just had their shoes stand in line for them. These systems that are disrespectful of people's time, energy, and attention, that are indifferent to the fact that people don't come to hospital because they offer cool services, but because they need the care because they're suffering. That indifference is cruel, and cruelty should be treated like wrong-sided surgery, must be eradicated from healthcare. And at the level of the clinical encounter, we know we have arrived when we're able to actually have unhurried conversations. These are not long and wasteful, but they're focused on the problems of the patient, but they feel like the patient has made time for me to listen and understand my circumstances, and I get enough of a chance to get right what is the problem that I have and how are the current solutions not working out. And we can see the patient situation in high definition, and develop in the process resilience and longitudinal relationships that are going to be important when we have to deal with the most common outcome of chronic disease care, which is the disappointment. And it's in disappointment that we go back to those relationships that we have formed in the context of those unhurried conversations. And it's also in those unhurried conversations where we form plans of care, we co-create plans of care, working together in shared decision making until we find a solution that makes intellectual, emotional, practical sense for this person at this time. A solution that makes the care program fit well in the course of their lives, as opposed to where I train, where the patient is lying in the hospital bed and you come in and do things to them until they are fully recovered. Chronic care requires us to weave our treatment programs in the fabric of each person's lives. And people that have multiple chronic conditions usually have complicated lives. And so that weaving work is going to be collaborative and difficult and it's an ongoing struggle to make that care fit. What is care that fits? What is the work of making care fit? This is put forward in an international manifesto from patients and clinicians that came out about 3 years ago. And they have this beautiful line in it. Patients and clinicians must collaborate in designing care plans that maximally respond to each patient's unique situation and priorities while minimally disrupting their lives and loves. This should be the core element of determining what is the quality of the care that we are able to offer people. Now, the argument is there's no time for all of this. There's no resources for all of this. This is a utopia. I mean, forget it. And I think there are some opportunities here to look outside of the healthcare system and make what I just described more feasible. There's a lot of work that is done in healthcare that takes a lot of time from primary care, and which is about prevention. The notion of prevention of one patient at a time with a clinician discussing with patients is massively expensive and wasteful. We should go upstream and do health prevention and promotion where it belongs in public health. So if we want careful and kind care, we need to have significantly more investment in public health. But we also have to do something more cultural here, which is to elevate care. Um, Usually, when somebody has a problem of health, the tendency increasingly is to seek professional care as a response to all forms of suffering. And not all forms of suffering deserve or require professional care. Many of them could be dealt with in the community with each other, but we've undervalued care. And as we've allocated it mostly to women, and increasingly to women of color and migrant women, who are increasingly given this task of care that during the briefest of periods during the pandemic we called essential. But since then we've forgotten. It continues to be underinvested in, underfunded, underrecognized, hidden work. And I think we need to elevate that form of care, make it more democratically distributed. If you deserve to be cared for, you have a responsibility to care for others. Talk about solidarity and develop skills in caring for each other, from basic education. The only place where we've really done this, in my opinion, is in cooking. We have people proud of their ability to cook the different dishes and share it with loved ones, feeding other people with their wonderful skills. We have cooking books and cooking shows, and we know that cooking has become an elevated form of care because men are now being paid a lot of money for doing the cooking as famous chefs. When men get paid a lot of money about something, society recognizes that as a valuable thing. And we need to make sure that is the place where we elevate other forms of care as a critically important part of our economy, not just the productive economy, but what people sometimes call the reproductive economy. When we do that, when we expand the possibility of responding to suffering with common care, we reduce the scope of work of healthcare as professional tasks. And so the future should see hospitals, clinics, and other healthcare professional responses actually shrinking as we expand the capacity of communities to care, not expanding infinitely as it seems to be the case now. And then finally, we need to remember that to care is fundamentally human activity. Everybody listening and seeing this presentation and participating in it is here because somebody chose to care for you. The mission feels infinite and it's overwhelming. The capacity to care is not infinite. So we need to make sure that we create the conditions in which care is possible, in which, like Maria Luisa, her family can find the care that they need, both in the healthcare system and at home, and eventually see Maria Luisa enjoy her life. What are we willing to do to get that smile? That when we see that smile, care doesn't become as overwhelming. Care, in fact, becomes a renewable resource if we are able to cultivate care as the core reason our healthcare systems work. The Patient Revolution, which is the organization I deeply mentioned at the beginning, is an organization of care activists who are working all over the world, locally, with immediate action within their sphere of influence to move away from industrial healthcare to careful and kind care. So we provide a support and courage to those activists as they move around the world making a difference. We also have a school that is providing skills both about what care is and should be, and the change necessary, the change management necessary to bring it about. Everywhere. And we have a greenhouse where we try to generate new ideas and tools to make this revolution happen. One of them is the book Why We Revolt, where we summarize some of the ideas that I presented today. And as an organization, the Patient Revolution provides both administrative and moral backbone to this organization that is trying to create in the world a healthcare that is based on solidarity and not greed, on integrity and not rules and regulation, on elegance and not just efficiency, and is care for this patient, not for patients like this, that is minimally disruptive of people and is capable of relationships of love. So I invite you to join us in a movement for careful and kind care for all. Thank you very much for your attention.
Thank you, Victor. That was really enlightening, and definitely, all of us have takeaways and lessons learned from that presentation. So thank you for that. Ikram, I'll turn it over to you if we have any Q&As or questions. Otherwise, I have a few that I can go ahead with.
Yeah, Deepti, please, you go ahead and have it, and then I will go after that.
Okay. So Victor, my question is, I work in the space of AI and digital patient care, and I actually am a digital disparities researcher. So my question is, you might have seen the article that we published through the University of California system, where the AI responses to patient questions were more empathetic than the human responses. Do you think that is because of what you presented? Clinicians are pressured for time, or they don't know their patients as well, or they just don't recognize the value of that asynchronous communication. And does AI have a role? Because you talk about the touch, which is human, you talk about empathy, which is also a human characteristic, and yet AI is outperforming. Where do you think is the sort of landing spot for that?
Yeah, I think it's complicated. I think the study is wonderful, but most of the interpretations, in my view, have oversimplified the findings. Basically, have this: either they see the. Well, let me take a step back briefly. When technology is brought into healthcare, usually it's predicated on the notion that the clinicians cannot possibly know everything, right? And why not have a separate brain? And when I was in training, it was several little manuals that we kept in our white coat, and eventually became a Palm Pilot or some sort. And then historically, people have carried their auxiliary brains with them because the massive amount of information and guidelines and other things just overwhelms. And so people have thought, oh, can we not have one of these auxiliary brains that could help us with the cognitive tasks? It's interesting to see how very quickly the frontier of that technology has said, well, what about the emotional task? Maybe we can take care of the emotional task too, because you're burnt out and overwhelmed and you can't really mobilize positive emotion 24/7, right? Because you're a human as well. And so why don't we just take over that for you as well? So it's interesting how we are basically chopping the care encounter, virtual or in person, into components and letting that technology pick up those components, almost as if we were redesigning the machinery of a factory, in which, well, that was very dangerous for humans to do. Let's have the robots do it. Oh, this is also the humans are slow, so let's have a sensor do it quickly, and so forth. And we begin to chop up the manufacturing process so that machines can do it better. And I think that's the key thing. What is better? What should AI be doing here that is better? And who decides what is that needs to be done by the machine? Who decides what better means? In this case, the judgment of how empathic the statements were was what was considered better. And then you have to make a judgment. Is the AI has a superior heart in being able to be more empathic, or is this actually an indication that clinicians are in trouble? Now, I'm assuming, which is not the case of that study, that these are real-time responses to real questions in the course of ongoing relationships of care, which was not the case in that particular study. But if that were to be the case in the study or in reality, you have to choose: are machines better than humans, or are your humans working in such horrendous situations that even a machine seems to show more heart? than the burnout clinicians that you're bringing to the fore. And so, to me, I rather think of this as, wow, our clinicians are really in trouble. They cannot communicate in empathic ways, and we should probably work towards creating the conditions for them to do that, rather than to turn to the machine to replace. You can't do that anymore. So we'll take care of that for you. It seems like it gives up on our clinicians, and their ability to communicate. It also communicates to the clinician that work is actually not that important, that they should focus on some other work that might be more important for them to do. So the cognitive work, don't worry about it, we can handle that. The emotional work, oh, don't worry about it either, we can handle that. So what is it that you get to do, right? And so some people talk about clinicians doing motivational work, that maybe what clinicians can do is motivational work. And that's all very sad. I don't, I am a big believer that care is something that we should decide is a human activity, and make sure that we have the systems in place to support our ability to perform to the best of our capacities, rather than seek ways of replacing us.
Yeah, well said. And I 100% agree that the root cause for why the AI was more empathic was the latter. Clinicians are burnt out and have no time. I mean, as a primary care physician, we receive over 1,100 messages a week. There is no way for a human to respond. So that's a good segue into my
Well, hold on,
next.
hold on. But so there's no way for a human to respond, but that should not then. Many people will hear that and say, therefore, we should have the machine
No,
respond.
no,
Yeah,
no, that's
yeah,
not where I was going. No, it is. As a primary care physician, I know my patients. So I know I can tailor my responses to my individual patients. But my panel is too large to have that time for empathy at 8 p.m. in the night to be
yes,
responding in that manner. So yes,
yes.
I'm totally cognizant of where you're coming from. But it's a good segue into my next question, which is healthcares are systems, they are businesses, and they are working on very thin margins these days.
Mhm.
How do you create that care ecosystem where there is time for all of this to happen while also managing the pressures that are on you to, have that positive margin?
Yeah. I think, just to be clear, I do believe in positive margins, right? The and Because we need those margins to continue to innovate, and we need those margins to maintain a dignified environment, virtual or real, for care. I got received my training in Peru right after hyperinflation and terrorism completely destroyed the infrastructure, both physical and moral, of healthcare in my country. I know what it looks like when you stop investing in maintaining hospitals and having the resources. And everybody learned what happens when you do too much lean and you have no personal protective equipment for your frontline clinicians for the next pandemic, right? So you need positive margins to actually be ready, to be redundant, and to be forward-looking and innovative. So how does one get those positive margins? One historical tested way, which is to disregard the investments necessary to care well, and to try to squeeze more labor out of the frontline clinicians. So basically, accelerate, crank up, look at the access challenge we have. You need to see more people in less time. And now we're bringing technology in so that during those times you're with people, the technology can do more of the work, so you can even see more people. And so, for instance, ambient scribes, I think, are the current approach that is people are very excited about. And if you don't protect care, the need is infinite. So it's always going to be further cranking up. And of course, we're going to run out of trained health professionals to do that work. And we're going to find opportunities in people with less and less training to do more and more of that work. And that, I think, is an undesirable track. I'd rather, again, I'm all in favor of elevating the care capacity of the population. So I'm interested in more and more less skilled people doing more and more care tasks. But I really want, when people need cure, to have the best possible folks that can cure them, and when they need care, that they have appropriately trained folks. Um, the so one thing that we haven't done in healthcare is ask what less can we do? Not what else can we do, but what less can we do? And this is a bit weird for me, but I'm increasingly excited about the idea of completely getting rid of prevention. I'm talking about primary prevention. In other words, picking up healthy, um, asymptomatic people and subject them to routine healthcare visits. I think they take a lot of time. Their value is very limited, and they have become a way of spending a lot of money instead of doing that something that is actually politically much harder and has been rendered almost impossible after the pandemic, which is to invest in public health. I think that the idea that we're going to prevent diabetes, which is what I see as in clinical practice, that we're going to prevent diabetes by identifying people that are over 40 overweight and have higher blood sugars, and then sending them to a YMCA so they can work with a personal trainer and then come back into care and then see if it's worked, and if it hasn't worked to start metformin. That medicalizes 30 40 35% of the population just on that one condition, and takes a lot of space from clinical care of people who are actually sick. With a colleague in Sweden, Mina Johansson, we put out a concept called time needed to treat, like the number needed to treat that you're familiar with, but this is time needed to treat, which is a way of asking guideline developers to say, okay, you want primary care to do that other thing now? Okay, figure out how much time will it take to do that on the proportion of this person's panel that satisfy the criteria of eligibility for that, and add that to the time that they're already spending doing all those recommended activities. And there's colleagues of ours that have come up with this estimate that a clinician will need 27 hours just to fulfill our recommended activities, and more is added to that list. So we need to start asking very seriously what less can we do in healthcare, and what more can be done with changing the political, social, commercial, and economic determinants of health.
Well said. Ikram, I'll turn it over to you in the last few minutes here.
Thanks, Deepti. It was good hearing Victor in this presentation, even though I had privilege talking to you in great detail. And good to see your picture of the cruelty where the people have put the shoes. And I recall that when I was used to travel in those underserved regions, people used to be in the queue since 4 o'clock, going to the doctor physician's office, and they're sitting 4 or 2 o'clock in the morning by the time doctors comes, and we don't know that if they don't know that if the doctor will be able to see them, because doctor will be there for 2 hours or 3 hours. He can finish certain number of patients. So my questions goes back to you that it's good that we are thinking in this high resource setting. This is one of the most highly dense resource setting, and vast part of the world have very, very thin resources or no resources. So when we think about this patient evolution and care part, what's your thought that we can overcome with those less resources and such kind of cruelty which is there with having more care mindset?
Yeah, well, the problem with the pathologies of care are more likely to occur when where there are fewer resources for care, and there seem to be at least three mechanisms to get that. One is poverty, right? That's what I saw in Peru. There was just not enough resource to put into healthcare, period. The second one is political decision towards austerity in social programs, and this is where politicians, for ideological reasons, decide to underinvest in healthcare, underinvest in education, and the consequence then is premature disease, and now you have a lot of patients that you have to take care of. We have societies that create patients by virtue of political, economic, social decisions, and so then the healthcare system is just not able to tolerate that. The problem is not to expand the solution is not to expand the healthcare system, is to deal with the political, social, and commercial problems that created the disease in the first place. And then, so austerity is the second one, and the third one is value extraction or profit extraction or just profiteering. And in many developed countries where the funding is publicly focused. It's a combination of austerity and profiteering, austerity from the government funding and profiteering from those providing the services. In the United States, a combination of all three, because we have multiple economies in the United States. Some places that are poor, that are just don't have the resources to invest in healthcare. Others that politically decide to cut back on healthcare benefits to people, and others there is this extraction of value. In the poverty one, I'm going to add that it's not just material poverty, but also human poverty, in that many healthcare professionals, administrators, and others come into healthcare poorly trained, and so incompetence leads to a lot of waste of resources and so forth. So in resource poor environments, the solution is investment, investment, investment. The sustainable goals from the World Health Organization require us that we invest in the environment, that we invest in education, that we invest in quality of water and food, and we invest in immunizations. We create health, public health for the community. And when people get sick, that we have dignified, well-funded healthcare systems with clinicians that are there. And by clinicians, I mean anybody, again, anybody with the privilege of the bedside, that are actually properly trained and supported to do the work that they have to do. We have a new crisis in the Southern Hemisphere, to speak broadly, which is a crisis of care of a different nature. As the Northern Hemisphere's economic engine continues to ramp up, and not just one, but two members of a household have to go and do work outside the house, there is a need for care in the house of children and elderly people, of people in nursing homes. And so, where is that care coming from? It's coming from mostly immigrant women of color from the Southern Hemisphere going to the Northern Hemisphere and doing that care work, leaving creating a care drain in the Southern Hemisphere. So whatever care troubles we'll have in the Northern Hemisphere, not only where we are well-resourced materially and scientifically, but also potentially well-resourced humanly, in the Southern Hemisphere, we have a crisis where we have a more extreme environmental impact on health, more extreme economic impact on health conditions, and more extreme lack of caregivers for people, even before they even get to the hospital or after they leave it. So the crisis of care is a real serious crisis, perhaps second to the environmental crisis that we face. I think it's existential, and it requires a serious rethink of the social, economic, and political conditions in which we are fostering our societies. The solution cannot be at the bedside. The solution cannot be in the doctor's office. This is a solution that requires a much bigger thinking, and we need to make sure that it doesn't end up depleting the possibility of caring for those who are sick, which I think is what we're seeing now.
Thank you, Victor. I think that's a great reply, and I come
Yeah,
from that setting. So I like
yeah.
to, even though I have so many questions, but paucity of the time, and I love talking with Victor, and I will look forward to catching you again sometime in person. But I like to, because of paucity of time, I like to hand over to Deepti and to take it forward from there.
Yeah, no, I want to thank Victor. I mean, this was so enlightening and so much food for thought here that I think we all have lessons learned and takeaways from this talk, and we'll definitely have to continue the conversation at some point. So I want to, thank you for taking the time this morning to present to us, and we will have follow-up questions as time goes on, I'm sure. Thank you.
Looking forward to those. Thank you for the
Thank you.
opportunity, and please take care.
Thank
Thank
you.
you.
Bye now.